Good morning, everyone. It's a pleasure to be here. I'm Dr. Bagnado, but for today and in general, you can call me by my first name, Francesca. I'm Italian, so that's where the name comes from. I'm one of the doctors at the Vanderbilt MS clinic, and also I work at the VA in Nashville, next door to Vanderbilt, where I see veterans with multiple sclerosis. So today, I will be talking about what goes in the head of the doctor when she or he sees you in clinic. And we are going to talk a little bit about the disease and what doctors can do for this disease and what you can do for yourself. When I started this in the 90s, I would, if I would have to give this talk in the 90s, I would have spoken very, very differently. But now things have changed. We have many more medications, but we also have come to know many aspects of MS that we didn't know before. In part because the disease, we didn't have all the medications we have available today, and patients were not doing as well as they do today. Feel free to ask any questions, either at the end of the talk or during the day. I'll be around all day long, so I'll be happy to be approached at any time. Okay, so with that said, let's start. Today we're going to be talking about how we can manage your MS, how you can manage your MS. And so we are going to look at the cause of this disease as a start, and we are going to look at how we can manage the symptoms as well. Now, if we imagine that this is the life of an MS patient, okay, and on the bottom line, which we call X line, but we're going to call it bottom line, it's time, right? It's your lifespan. And then on the vertical line, it's your disability. I don't know if you have ever heard, but the doctor gives a point to your exam, and we rate the exam with the Expanded Disability Status Scale score, or EDSS. So for today, we're going to learn that the EDSS is the measure of disability. It's a scale that was designed by John Kurtz, who was a Marines and the military and neurologist that worked in Baltimore. And his studies have really allowed us to understand a lot about the MS epidemiology, how MS starts in different patients' population. So the EDSS score goes from 1 to 10. Now, the way the disease starts, is that at the beginning, there are some active lesions. I'm sure you have heard from your neurologist whether or not you have any active lesions. And studies have shown that patients have symptoms every 10 active lesions. Okay, so up to 9 lesions may sit in the brain active without giving you any symptoms. Those are numbers that we generated at the NIH in the old days when we did not have disease-modifying agents for MS, and patients had a lot of activity. But that's why MRI is important, because many times it can let us see activity even in the absence of a clear symptoms. Eventually, one of those symptoms becomes an exacerbation. And then over time, I'm going to turn around. Forgive me if I'm not looking straight, but I want to make sure I manage the slides well for you. So eventually, these symptoms are going to give us an exacerbation, and this is when you see your neurologist for the first time because you have numbness and tingling or weakness or problem with the vision. And so we call this part of the disease relapsing remitting MS, which I indicated by the yellow graph, right? And the disease has the ups and downs that we are all familiar with, right? And we give steroids, and then eventually we can go back to baseline. Now, this phase of the disease is called relapsing remitting multiple sclerosis. I'm sure you have heard about that. And when I started this, there were no medication for relapsing remitting multiple sclerosis. Now we have more than 10. Okay. And so the goal of those medications is to prevent new lesions to form. And so by preventing these, we prevent new relapse to happen and therefore further disability to accumulate. Now, there is a phase of the disease after this where the number of active lesions become a little less, become a little smaller, yet people perceive that they are getting worse, right? Sometimes I ask to my patients, what can you do today what can you not do today that you think you could have been able to do last year? And then when people think about, they realize that there are things that they cannot do today. And this is true for every one of us as we age. If you ask me, what can you do today or you cannot do today that you were able to do a few years ago, I can give you my good list, you know? So this is part of aging, but MS works with aging, right? And so it kind of make that list a little longer. And we don't realize this on a day-to-day basis. And we call this phase of the disease secondary progressive MS. And what the doctor sees on your MRI sometimes is that the brain tissue kind of shrinks, and so the spinal cord tissue. And in a way, we all shrink as we get older, right? None of us gets taller. That phase is gone. And the same applies for the brain as well. All our organs eventually shrink. But in the case of MS, the brain and the spinal cord may shrink a little faster. And I'm very disappointed to say that we have yet to find that medication that acts upon that shrinkage. And when that medication, patients always ask this question, and I think this is a very important point to understand, that that shrinkage is a lot the reason why things seems to get worse over time in a sort of a smoldering manner. And this is a problem not only in MS, this is a problem for a lot of neurological conditions. And I can guarantee that if that drug will come in the market, we will all know, because it will be a gigantic deal. It will be one of these big book chapter of the history of medicine, because it will benefit so many patients with so many neurological conditions. So you can rest reassured that your doctor will tell you that this is happening and this has occurred, and you know, and that will be a significant breakthrough. Now, when I started this again, I used to say that ideally we would like to discover the disease before it becomes symptomatic, because I'm sure every one of you has experienced that the day of the first symptom, when they saw the doctor did an MRI, and the MRI already had lesions. And so when did those lesions came? This is a question that we have not been able to answer. We don't know. But nowadays, there is a lot of use of MRI. People get an MRI for many reasons: for a fight with insurance, for a car accident, for a headache. And we are seeing a lot of patients that have lesions without symptoms even before the diagnosis is made. We call these patients radiologically isolated syndrome, and there is a lot of work now to identify those patients and treat them right at that point before they even manifest the first symptoms of MS. So this is all I think about each time I have one of my patients in front of me, and I try to understand in what part of the figures that patient fits to be able to answer in the most honest and appropriate manner the question that he has. Now, why do the lesions form? Okay, I made a cartoon for that, and my goal today is to leave each one of you empowered with the knowledge that the doctor has, because I think it's important. Because I think part of the power we have in life is to know what we want, to know where we want to go, to know who we are, essentially. So this is what we believe happens when people have inactive lesions. So here you have to imagine that the compartment that I have designed with the blue and red ovoids shape, right? Those are the vessel. Okay, so this is a vessel in your body, and each vessel has walls. Okay, and those walls are made of all those cells. The idea that we have is that every day in these vessels, we have cell of the immune system, which we call T cell. Okay? Each one of us has a number of T cells circulating in the blood vessel. Okay? And then what happens is that for some reason, they get exposed to an enemy. So say one of us now sneeze, that's it. A lot of bacteria, a lot of viral particles come out of that sneeze. And those cells sees that. And so they say, oh, something is going on. And so then they start taking their arms, start taking their guns that I represent here with this yellow triangle on top. And once they have those guns, they can go into the brain. Normally, this vessel would not allow those cells to pass the brain. Because imagine, if we didn't have this barrier in the brain, anything could go there. And so say that you now have 3 muffins, your glucose level goes up, all that sugar goes to the brain. In 1 hour, you guys are going to be all in diabetic coma. And I'm going to be talking by myself, right? So that's why we have this barrier, because we don't want anything to go to the brain. But then when those cells are activated, meaning that they have the shooting guns ready, they can cross the brain. And the problem is that once they cross the brain, they get confused. And they say, what's going on here? They don't recognize parts of the brain. And then they start attacking. And then at that point, the vessels break. And then there is an inflammatory reaction. A lot of other soldiers, a lot of other cells come from the periphery, like the B cell, which a lot of you must have heard. And then the war keeps going. And this is when the patient comes to us, has an MRI, and the MRI shows that there is the active lesions, right? And that's when the patient has the symptoms. When the patient has the symptom, all of this is happening in the brain. So we give steroids and we try to shut down everything, and eventually we are successful. But the way you have to imagine this, it's like a war zone, that there has been a battle, right? And there have been people that unfortunately died, there has been damage to the ground and to the regions where the battle is. And so even if the war is over, now there is the damage that war has done that we have to deal with, right? A lot of buildings shut down, a lot of people have died. And so the disability that remains after that exacerbation is essentially the remnants of that war. And in neurology, that means that sometimes the axon and the cell, which is the purple circle that it's on top, may be damaged. And so the myelin, which is the blanket that covers our axons. And the myelin is supposed to be all smooth in red, whereas after the exacerbation, that myelin is gone. So this is what the doctors has in mind when you guys see with a symptom. And that's why it's very important that you always notify your doctor if you think you have a symptom, because we can give you steroids, we can make that battle lasting much, much shorter. And as such, the consequences of that battle are going to be less devastating. The other aspect is that sometimes MS likes to hit the same site. So if you have a lesion on a specific site, the MS likes to hit that site for a second time. And the second time is always worse than the first time. So imagine that there is a country that has been bombed, right? And then there is another bombing in 1 year. That country has still not been able to restore completely, and now we have another bombing. And I apologize if this analogy brings not very pleasant memories, but I think it's very practical to understand the problem that we want to tackle. And so if there are areas of our brain and spinal cord that they are very small, okay, those areas are more vulnerable to the second attack. Okay. And so, and the consequences that they can leave are a little larger because, if you have a small area that has been attacked, that small area does not have a lot of resources, right, to help. If you have a big area, then there might be more helps, right? So that's why spinal cord lesions, we always want to be a little more aggressive. And that's why spinal cord lesions, even if they are small, they may leave more disability behind than brain lesions because the brain is much larger than the spinal cord. Now, the consequences of all of these are the presence of these lesions that we count on the MRI. And I'm sure you have heard from the doctor that you have lesions on your MRI. We call them T2 lesions. And this is one aspect. The patients are always very preoccupied. How many lesions do I have? I don't think that is very important. Okay. From time to time, 1, 2, 3 more lesions doesn't make a whole lot of difference. What it makes a difference is the overall general pattern, right? And whether or not you keep having new active lesions. This is what we care most. Now, some lesions, when they come, repair. Particularly in young people, the brain has a very strong ability to repair and remyelinate. Over time, those lesions do not repair anymore because we lose that ability. And it's also very patient specific. We don't know why some people tend to have lesions that repair. Okay, and some people don't have lesions that repair. But there is a small number of lesions that not only doesn't repair, but persist over time. And we can look at this lesion in a specific type of picture that we take, and we call this lesion black hole because as I show with the red arrow, it remains hypointense, we say in technical terminology, but essentially black. Okay, so black hole is the natural evolution of 25% of the lesions. And so one thing that I don't like to see on a patients that come to my clinic for the first time are the black holes. I don't care if that patient has 10, 20 lesions. I care more that he does not have a black hole because I know that black holes are a sign of more aggressive damage that has been done on that brain. And in fact, the black hole correlate with the clinical disability. So ideally, we want to have that drug that erases the black hole, right? We have it, let's repair it. We don't have that drug. We are fighting to find that. But one way we have to avoid that black hole to happen is to avoid that active lesions to come in the first place, so that will not evolve into a black hole. Did I make this concept clear? If not, raise your hands because I'm here for you. Yes.
Showing active lesions, but I had one in November and then just one recently, but I had more black.
From November to today? Yeah. And this can happen. Yeah. And so your question is, what would you like to know? So no, I agree. So we don't know why some patients, so we don't know why some lesions have more tendency to evolve into a black hole more than others. And even within the same patients, there are times in life where lesions tend to evolve into a black hole and times when they do not. One aspect that favor the black hole is that if that active lesions last long. The longer that active lesions last, the higher the likelihood that it's going to turn into a black hole. So because of that, you probably, I don't know if you're already on a treatment, but, preventing aggressively those lesions to form, it's really key. Now, the other aspect that you need to know is that if your MRI was done at 3 Tesla, okay, and the black hole were looked at on a specific type of picture, and I can go over that detail later on. Yes, then, nowadays we have more sophisticated MRIs and we see many more black holes. So it's possible that not all of them are that severe. So I will need to know exactly what kind of sequence is being used. Yeah. Yes. Yeah. Yes. Yes. Yeah. So she is asking what I mean by active lesions and how long does an active lesions last. So active lesions are those lesions that we see after we inject the dye. You have an MRI and then you inject the dye. And after the dye, nothing should bright up. If something brights up, that is an active lesion. And if you have several active lesions, you may have a symptom. Normally, patients come to us when they have a symptom because they don't have an MRI every day to see if they have active lesions. But if we find an active lesions on an MRI, we also like to intervene and make sure that we shut it down with the use of steroids. If we leave active lesions untreated, if we don't give steroids, the vast majority last 1 month, but they can last up to 6 months. But with the use of steroids, they're gone in a few weeks. 10 minutes? Okay. I prepared so many slides, but I have only 10 minutes remaining. And so, and so it does not matter. So what I'm going to do then, 25 minutes. I got it, a sign of 10. Okay. So one thing that I want to say also, because this is coming in future, in the next future, and those are all new concept, is that when we have an active lesions, which is the one that brights up after the contrast, these active lesions, once we shut it down with the steroids, has 3 possible evolution. Okay, one evolution is that repairs completely. Another evolution is that it becomes chronic inactive, meaning that there is damage. Damage is done. We cannot erase that damage, but at least the lesions doesn't change. But a third evolution, which is something that we have discovered recently, and that Vanderbilt has been pioneer for this discovery, is that some of them can become chronic active. So they don't take the dye, but there are some cells that remains around that lesion, and those cells are called microglia. And these allow these lesions to slowly expand over time. So it's a lesion with the smoldering fire underneath. Okay? So the way we want to imagine those lesions is that there is a fire in your fireplace, and this is the active lesion. Okay? Then you turn off the fire, you clean everything, and that is a remyelinating scenario. And then you turn off the fire, you leave all the stuff there, but nothing is happening, and that is the chronic inactive. But then you turn off the fire, and there is still a little smoldering, right? Little smoldering, and that is the chronic inactive. Okay? And now the goal of the next generation of medications is to suppress that chronic activity. Yes. Yeah. So now we can see those lesions on MRI with a specific picture that we are incorporating on all the scanners. We call those lesions paramagnetic rim lesions, PRL. Okay, P as in Paul, R as in Roger, L as in lemon. And now we can see PRL. And we look at them. They're going to be part of the diagnostic criteria because they're very specific for MS. And the next decade of science will be all towards finding a medications that shuts down those PRL. Yes.
When you look at the lesion, can you tell if it's in
Yes, Yes, sorry. When you look at the lesions, can you tell if it's active or inactive? You can tell if it's acutely active with the contrast dye. If it brights up after the contrast dye, it's acutely active. If it shows as a PRL, it's chronic active. If it doesn't have any one of those features, it's either a remyelinated lesion or a chronic inactive. Unfortunately, we are not able to distinguish them. That's why, when we do the T2 image, when we have the classic lesion count, that's why that count is to some extent irrelevant, because we don't know who is what. It's like taking a picture of this audience with all the face blurred. We don't know who is who. Then we are going to adjust the resolution, we're going to adjust the contrast, and we're going to start seeing, oh, here we have a person that has eyeglasses with a dress with some flowers, and here we have another one with eyeglasses as well and long hair, right? And so the classic MRI that we have, we see all the pictures. It's like having a picture of this audience with blurry faces. Doesn't make much sense to count. Yeah.
Okay, earlier you was like, at a certain age, the lesions in your brain can still heal. Do you know like what age do they like possibly still can heal and still like not gonna heal?
Yeah. So we don't have this number, and I'm going to tell you why. Because we know that lesions heal and not heal, because we have done a lot of studies on the autopsy table. We look at those brains and then we count the myelin. And at that point, it's hard to say which one, when each lesion was formed in a certain way. So we don't have that answer. And that's another concept that I want to leave to this audience. Sometimes I sit on your chair, right? I have sitting for many years in the chair of a caregiver. And so I know where the desire to know things in a very precise manner come from, much better than you can imagine. But I also want to tell you that we need to make some peace with the fact that we don't have standard numbers, to say before the age of 25, you're going to repair all your lesions. After that, game is over. Or things like 3 lesions are very good, 4.5 lesions are the end of the game. What I want to share with this audience are concepts, okay? And what I have learned over the years, with my research studies on MRIs, is that not every patient, so patients are very different from each other. So I think it's important that we talk, and that you guys exchange experience, but you have to make a barrier, because your MS may be different from his MS or the MS of someone else. And even within your MS, things may change over time. Yeah. Yes.
Does a black hole equal axonal loss?
Yes.
And can the brain reroute around axonal loss?
Yeah. So black hole equal axonal loss. It doesn't equal 0 axons, but it does equal that a lot of is equal 90% of axons loss. Okay. The way you have to imagine a black hole, it's like a highway. Okay. I'm going to give you the example. So the black hole is, you have a highway. Okay. And the black hole is like a car accident in the highway. Okay. So what happened at that point? It happens that there is traffic jam, right? Because all the cars slow down. Some is because they just want to look at, and some is because they cannot pass, right? In the brain, there is not such a thing that they want to look at. The brain is very focused on what it has to do. Now, over time, right, police come and, help comes and they do the detour, right? And so we do the detour and the traffic can still go. It might be slower. And that's why, for example, if it's very hot, you feel like you go down a little bit, but the traffic still goes and you still maintain the function, meaning that you still can go from your house to your job or to anywhere you wanted to go. If you keep having accidents here and there are so many detours that the police or the city can build to make that route efficient. Right? And so at that point, the route is no longer efficient. People may take 3 hours for a journey that should have lasted 20 minutes, and sometimes it may be impossible. So to answer your question, yes, one black hole, the black hole per se cannot be repaired. We don't have that medication that repair, but the brain has an extraordinary ability early on to make the detour. It depends on how many of those black holes we have, and then the brain loses the ability to make detour. And with that, I want to say one thing, because I know at some point people are going to start flashing, and I have some important slides at the end of this talk, and we are so very far from that. And I'm so very happy, because this means that we had a lot of questions. But I want to say one thing, that when I started this, we thought that it was all about MS. But the reality is that, we doctors can act upon the lesions, but you patients can act upon the detours. Okay? And so if you have a lesion or 2 or 3 and your brain tries to make detour, but then your brain has a lot of structural damage already, a lot of damage that we don't see, but we know is there, because you have hypertension, diabetes, high cholesterol. Those, they're really a killer for the vessels, okay? And we need healthy vessels to make those detours. So if those lesions happen in the middle of a brain, I'll give you the time, sir. In a brain where there is a lot of what we call vascular disease, atherosclerotic disease, then the ability to make these detours is going to be less and less efficient. So that's why it's very important that as a patient, you work for that brain that is still healthy. We take care of you not forming lesions, but you take care of maintaining the detours possible by keeping yourself with a healthy style. So maintaining good level of cholesterol, maintaining your blood pressure at good levels, keep an eye on what you eat and the diabetes, and make sure that when the brain needs you, when the brain needs to make those detours, doesn't find a lot of, roads that they're not just good because the head suffered from the injury, from high blood pressure, high cholesterol, diabetes, and all of that over the years. Sir.
A little over 2 years ago, I was diagnosed with solitary sclerosis, and it's difficult to find any information on the internet about it. My understanding is one lesion, but yet the progression, it's like primary progressive. And just wondering if you knew of any active research or any resource just to find out more information about solitary sclerosis.
Yeah. So we can help you. I don't know if Dr. Shah is here. We can help you with that. We can meet you individually and help you with that. For sure. Okay, so I'm going to keep going until I have another flash. I have to anticipate that this talk is not going to be, terminated, but, we can decide if we want to meet again via Zoom or, during the day. Somebody asked, can we see chronic active lesions? Yes, we can see them. This is how they look like. They look like a dark rim, and they look like paramagnetic rim lesions. So I want to really give you this knowledge. You need to ask this to your doctor, because this is going to become MS. This is how MS 2025 will be. I also want to give some concept regarding the brain shrinkage. So this is the brain on the right of a patient after 2 years of disease, and this is after 14 years. And you can see that in the middle, there are these dark holes that they are called ventricle, and the ventricles enlarge over time because the tissue shrinks. Now, we don't see this much anymore, because this is from a patient that I saw when I was at the NIH at the time when there were no disease-modifying agents. So this is what would happen back in the days when we did not have MS medications, that the brain would shrink, and this is how much the ventricles will enlarge to take that place. Thankfully, this is history for the vast majority of the patients today. Now, the second part of my talk was supposed to be about MS symptoms. That means 10 minutes. Yeah, okay. So MS symptoms, are related to where the lesions is. And in MS, lesions can be anywhere. right? Can be in the spinal cord, can be in the brain, can be in the optic nerve. When we teach MS to the residents or to the students, we tell them, if you see a neurological exam that doesn't make much sense because it's so kind of all over, that is MS. Because people can present with symptoms in one leg and symptom in one eye, and those are so different, the way they are located in the brain, that, but this is what MS can be: random in terms of when it happens and randoms in terms of when it presents. And based upon where the symptoms are, we can act with symptomatic management. So all the disease-modifying agents that we have available, that you guys probably are aware of, are all to prevent new lesions to happen. Okay, but then once those lesions have occurred and once that damage has been done, that damage means symptoms, right? And those symptoms are very annoying. And so, so we have said that. I was saying that, we have a lot of medications, and I just wanted to show this slide to give you history and to give you courage. So this is an historical slide that was done back in the days. And this was the slide that brought to the approval of the very first MS medications, which is interferon beta. We almost don't use interferon anymore because now we have many more other drugs that have proven to be even stronger. But if you count those bars, each bars represent monthly MRIs, the number of lesions that we could count on patients on a monthly basis. The first 6 bars are the pre-therapy phase. So look how many lesions patient would present on a monthly basis before treatment came. And then treatment came, and look how they went down. So clearly, the treatment have made a big, big change. And imagine that each lesion sees a car accident on that highway, right? And then imagine how many detours you would have to do if, on average, people had 9 lesions per month. Right? So this is how much the landscape of this disease has changed. And I wanted to show these slides to give hopes and to give courage, because we have gone a long way. A long way. So disease-modifying agents are key determinant of outcomes. I encourage everybody to be compliant with the MS medication. If you don't think you like your MS medication, talk to your doctor, have that medication changed, but don't stay without an MS medication, okay? Just be compliant, do what the doctor says, and if you don't like it, we have an array of choice today that we can change and we can choose from. Sorry, this is really... If they have any medications come with side effects, be open with your doctors about them. Don't be scared, don't be shamed, don't be intimidated. We can change them. You do not have to go through the side effects because there is no reason for that. We have a lot of those medications available to you. So my take-home message for you on this slide is to really encourage to have very open conversation with your doctors. Okay? We, doctor, can imagine what is going on in your head, but not completely. And I am 100% sure that none of my colleagues would not appreciate you coming through and, letting us know what is that you don't like of that medication. And none of us will be hesitant to work with you in changing if it doesn't work. But keep in mind that slide that I showed, right, with the number of lesions pre-therapy and the number of lesions after therapy. And keep in mind that as a doctor, that is the slide that we have in our head, in our front of our eyes, and that is where we want to bring you, to that other aspect of the curve. Okay.
We have a question from the virtual audience.
Oh, sorry.
Question is, you mentioned that there may be a medication for secondary MS. Do you think there will ever be one made for primary MS?
Yeah. So I am sorry if I came across stating that we do not have medications for secondary progressive MS. So all the medications that we have available today are medications that allow us to prevent new active lesions to form. But when the disease progresses independently from those active lesions, we still do not have a medication that allows that progression to slow down. Part of that progression is mediated by chronic inflammation, and we're really working hard to abate that chronic inflammation. But there are also other factors that are determinant of progression, and we have not been able to find anything so far. And this applies for both people with primary progressive MS and people with secondary progressive MS. So the only thing that we can do for people with progressive MS is to make sure we keep the reserves that their brain and spinal cord have as healthy as possible. So when those reserves are needed, they can be utilized to the best of the possibilities. Did I make myself clear? Yeah. Okay. So what as I said, we have a lot of disease-modifying agents for these conditions. Some of them are injections, some of them are oral medications, pill, some of them are infusion. Each one of them comes with its own side effects. Sorry. Okay. So I want to spend a few words regarding side effects. So some of those medications are immunosuppressor, okay, meaning that they are a little stronger on your immune system and they suppress it more aggressively. Typically, those are the medications that have the higher potency. We say that they have the higher level of efficacy. And so it's very important in this context that we monitor some parameters in your blood to make sure that the numbers that we look at do not go very low, because if they go very low, then the likelihood that you have an infection may be higher, okay? And so it's very important that us physicians do that, but it's also very important that you as a patient communicate with your doctor. And if you are in one of those medications like the injection that we give every month or the infusions that we give every 6 months, you pay attention as to whether you're having more frequent cold, more frequent UTIs, more frequent pneumonias, and you communicate this to your neurologist. It may not be relevant to you, or you may be thinking, I shared this to my PCP, but it's very important that you let your neurologist know, because those medications predispose to a higher level of infections. And so we want to make sure that we are prompt on them, that we treat them. And nowadays, we also have studies that are showing that perhaps spacing out those infusions a little longer is going to be just as effective, and is going to help us preventing more infection. So don't be confused or preoccupied if your doctor tells you we can space out your infusion a couple of more months, because we know that it's still going to be effective, and it's just keeping you out of trouble in a more safe manner. Other medications are less potent, but in my opinion, there is a cup of tea that is good for every patient. And so those medications, we call them immunomodulators. They do not expose patients to a higher degree of infections, but the downside of them is that they're a little less aggressive on the disease. I also want to share with you this concept, and the concept is that this is a time when the MS community is somewhat split, okay? Some of us think that it's important to treat MS very aggressively since the get-go on everybody, okay? Some of us think that there is a cup of tea for every patient, and there are times when a patient needs a more aggressive treatment and times when a patient needs a little less aggressive treatment. This is really split across the world. And I think both ideas are respectable, and a lot depends on your level of comfort. But I also have to say that a lot depends on your stage in life, on what you want to be exposed to, your level of disability. So those are all very important conversations that you guys need to have with your physicians. And when you exchange ideas and opinions and conversation among yourself, don't get stuck to the idea that there is one drug that is the best, and if John is taking this, then Steve should be taking the same, and why me, Steve? I come to you and I don't get this medication. Try to understand from your doctor what is the reasoning behind them. Because we tend to see our patients as a whole. When I see a patient in front of me, and I see a young lady, for example, I try to imagine her entire life. You know, to me, the patient is not the 20 minutes that she spends with me. I try to imagine this lady an entire life, you know, and see, does she wants to have children? Does she want to, what kind of job she does? You know, where does she want to be? And I try to prepare these patients for an entire life, more than just for their active disease at that specific time. Because it's important. Thankfully, MS is not a disease that is going to take you away. Nowadays, we have solved that problem. And so now that we have worked on the quantities of the days, we need to work on the quality of the days, right? And I'm going to be kicked out. But I'm here all day long.